Everything was going great. We went in for our 20-week anatomy scan, and that's when they told us that they saw a cyst, or what looked like a lingual cyst is what they called it, in her mouth. They said they couldn't tell if it was on her tongue, it was just somewhere in her mouth. They said this was super rare, that this was something they had never seen before. It was scary, honestly.
In this particular patient, we were noticing that there was a small cystic structure that was just in between the lips of the mouth that did not move. We could see the tongue move, but we noticed that this structure was pretty much persistent there at the lips, and the lips were not able to close. So that was our first inclination that there was something abnormal on her ultrasound.
Sometimes if they get large enough, they can sometimes affect the baby's ability to breathe and swallow. When you're a baby in the womb, breathing is not a priority because you're getting your oxygen from your placenta. But the second you're born, you need to be able to use your airway and breathe and take over for the placenta. And so we told her from the beginning there could be maybe some concerns with the baby's ability to breathe if the mass in the mouth was obstructing the flow of air.
We also wanted to investigate, are there any other abnormalities that may correlate with a genetic syndrome or any type of chromosome abnormality, offering patients genetic testing. And then once we kind of gather all of this information, we approach this as a team.
This baby has an airway problem where we need to make sure that we can get a breathing tube or a tracheostomy into this baby before it is completely born, so that we can make sure that the brain continues to get the oxygen that it needs to.
The procedure that we're doing is called an exit procedure, and so it is not quite like your standard cesarean delivery. An exit procedure is, in a sense, a cesarean delivery. However, it is not the same in that we don't go in and just deliver the baby all the way. We deliver just the head so that they can then be able to secure the baby's airway while the baby is still connected to the mom by the umbilical cord.
During that time, I will put a blade, what's called a laryngoscope, in her mouth and see if I can visualize her breathing cords, and then place a breathing tube while she is still connected to her mother for life support. Ideally, if we can secure her airway, meaning I can put in a breathing tube in her trachea, then she gets hooked up to a ventilator, and then we can deliver her and cut her, umbilical cord, and then move on to whatever surgeries she may need to repair the mass in her mouth.
The goal is just to make sure either the baby can breathe spontaneously or we can get a safe airway fairly quickly. The ideal plan is not to manage the lesion initially unless we have to get an airway for some reason.
The nice part is the multidisciplinary group coming together and all working together for one goal, where we're going to go through and practice everything that we need to do to make sure that we can account for any kind of issue along the way.
We use people from the NICU, from maternal fetal medicine, pediatric surgery, pediatric ENT, pediatric plastic surgery, anesthesiology, nursing. So it's been a large group of people that have been meeting frequently to work on the details of planning this procedure.
Breathing tubes in place. We've got a good strong heart rate. We're securing tubes here shortly. We're just listening, making sure we've got equal breath sounds bilaterally.
She said, watch me. Good job. You did so good. Congratulations. You want to come on this
A lot of coordination went into this. So, for us, the idea was to make sure we had choreographed this ahead of time as much as we could in terms of anticipating what could happen, several steps beyond, the initial step that I'm involved with. And so, things went as well as we had planned. I was able to, using the specialized video intubation equipment, was able to see her airway past the obstruction in the mouth, and was able to get the breathing tube in under 30 seconds. So it went in about as quickly as we could, and she was delivered and was stable throughout it, and we were able to maintain her in I think the best state that she could be throughout this procedure.
When she first came out, obviously, she was still over with Mom. So when they got that breathing tube in and got her over to the bedside with us, I mean, she was already fighting. She was swinging her arms. She was pink. Her eyes were not open just yet, but as we started to do and get her a little bit more stable, she opened her eyes right up.
I think it helped greatly to do our walkthrough the night before to know what to expect when we walked in this morning. But everyone was well prepared, and it went as smoothly and as perfectly as we could have asked for.
We probably over-prepare for a lot of these, and I think that's the point. The point is to over-prepare, and so for the one child out of however many that needs emergent intervention, you're able to salvage that child from a bad outcome.
They told us they had practiced, that I just had full confidence in all of them, all of the care, the nurses, anesthesiologists, everyone. And you'd think you would be super nervous that morning, but I honestly had a peace that I can't even explain.
There was a fluid-filled structure, and there may be some soft tissue in there as well, and it's under the tongue and pushing the tongue up. And so that was what was obstructing Charlotte's airway, is it pushing up against the tongue, and the tongue then taking so much space in her mouth, she wouldn't be able to breathe without that being taken out.
Once they were able to successfully intubate the baby, it was like a big, deep sigh, like, wow, we got it done, we got this baby out, and guess what, our mom is also doing great. So it's sort of a huge sigh of relief, but it's also, you feel like you got a good win out of care for that patient.
To be a leader in an institution like this that can put together just an extraordinary team, to be part of that team really is just a wonderful feeling. We want to be able to provide anything and everything that we can to families, and to be able to put this together, to have all of the work that went into it, and then to see the outcome as it already has been is just absolutely wonderful.
I feel like we were family to them. I remember the first appointment, I said that I was praying for someone that would understand and just be patient with us. And everyone we met was the same way. I just felt like they cared for us like we were important, and they wanted to take care of us like we were families.